Now coming to next slide. So I have already mentioned that what are the difference of cardiac dyspnea and respiratory dyspnea. NY is the grading, and you have to know the grading system details and explain the grade, and do you know the other grading system? This is generally is not asked, but you have to know about the NOS grading system. This is very important. And all the thing, like you have to know about the approach of shortness of breath, chest pain, palpitation, like what are the causes, clinical feature of congestive cardiac failure, features of pulmonary arterial hypertension, what are the differential diagnoses, can you from this history. So you have to know the differential diagnosis of your case. So, and why are you taking this history, like why are you asking regarding this pedal edema in the negative history. So you have to know regarding your case. First history suggestive of rheumatic fever, as already mentioned, that there was no suggestive history of hypertension, diabetes, thyroid disorder, TB or TB contact, trauma of chest wall, surgery. There is no event of sudden cardiac death, ischemic heart disease or any similar issue in her family. Now coming to personal history and social history. She is living with her husband and 2 offspring. She is belonging to lower middle class according to the Weather scale. So it is mentioned earlier. So you may not mention here. She takes mixed diet, no history of chewing tobacco, smoking, alcohol consumption or any other substance use. No suggestive history of high risk behavior. High risk behavior. What is the importance of taking history of high risk behavior? Like you are thinking about infective endocarditis. Now bowel habit frequency is 1 to 2 per day for last 20 days. Bladder frequency is increased after taking medication. Sleep appetite decreased. She is taking an injection of 21 days interval at 21 days interval, and menstrual history within normal limit. So you have to mention a treatment history or drug history, menstrual history. Now coming to summary. So Mrs. Anjali Bag, 30-year-old normotensive euglycemic female patient, presented with insidious onset, gradually progressive shortness of breath and palpitation. Both was NOS grade 2 and cardiac origin with past history suggestive of rheumatic fever. So you may write like this. So don't write like cardiac origin. So you may modify this. Okay. Now general survey, patient is conscious, alert, cooperative, oriented to time place person, and decubitus was of choice. So remember, in cardiac case generally it is not decubitus of choice. Many time it is popped up position, and build is average BMI. In case of edematous patient, you have to avoid to mention a BMI, and in case of hemiplegia or paraplegia, you must have to avoid BMI. Why? Because in case of hemiplegia paraplegia patient, the patient is in supine position. In supine position, you cannot measure height. So if you cannot measure height, you cannot measure BMI. Nutrition average. Many times it is nutrition is malnourished, but as the patient was nutrition was apparent. Faces no facial faces noted, pallor mild, icteria scrubbing, cyanosis, pedal edema absent. Skin changes, IV canal noted on the left wrist joint, no nodular rash. So you know why I'm asking about nodular rash. And in sometimes in aortic regurgitation cases, you may mention locomotor brachialis in skin changes. Okay, lymph node not palpable, thyroid gland not enlarged. You have to mention the thyroid gland. Regarding the thyroid gland in cardiac case, must have to mention the thyroid gland. Neck vein not engorged, that is JVP not raised, and you have to hepatojugular reflux absent. You have to know how to check JVP and how to check hepatojugular reflex. We will upload a clinical video regarding how to check JVP or hepatojugular reflux. Temperature not raised, pulse 78 beats per minute, regular, normal volume, arterial wall not palpable, no facial character noted, no radial delay or radiofemoral delay. All peripheral pulses are palpable. You also have to know how to check pulse, how to check the volume of the pulse, how to assess the arterial wall, how to check water hammer pulse, and where to check the peripheral pulse. You must have to know. We will also upload some clinical videos regarding this. So saturation 97% with the at a room air, blood pressure as mentioned. Okay, now mention the sitting position, and of course mention the unit millimeter of mercury, and respiration 14 per minute, regular thoracoabdominal type, no accessory muscle of respiration involved. So already mentioned, you have to know about the pulse examination, JBP examination, question regarding the pulse and JBP, and other examination like you have to mention decubitus, generally cardiac is decubitus, pop position check, and you may be asked regarding how to check pallor, where to check pallor, how to check clubbing. Systemic examination, inspection. So inspection is very important. How to localize apex, how to inspect a cardiac case. So inspection is very much important. And inspection, so inspection will be there from the right side of the patient or from the foot end of the patient at tangential view. Okay, so we'll also upload video regarding inspection, palpation and auscultation of the cardiac case. Now cardiac pulsation noted over the left side of the precordium, that is at the mitral area. Neither any chest wall deformity nor spinal deformity noted. No other pulsation over the back precordium noted except above mentioned. Venous dilation, scar, sinus polyethylene, etc. absent. So stay tuned with us like for the examination, detailed clinical examination. Now palpation, mentioned that mitral area apex is located at left 6 intercostal space and 1 centimeter lateral to mid clavicular line, and it is confined to one intercostal space, has an area approx 3 centimeter square. So avoid mentioning about the area. If you cannot measure the area, so avoid the mentioning the area of the apex. Like a 25 rupees coin occupied 2.5 centimeter square area. So if you can measure, then you can add this, otherwise avoid this. So at the mitral area, the apex is hyperdynamic, systolic thrill present, no palpable heart sound. Now second point, left parasternal hip. So you have to also examine how to check parasternal hip, how to locate apex. So left parasternal hip absent, tricuspid area, pulmonary area, aortic area, pulsation, palpable heart sound, thrill absent. Now you have to know how to palpate base of the heart. Base of the heart means pulmonary area and aortic area. So how to palpate base of the heart, that is pulmonary area and aortic area. Carotid thrill, palpable pericardial tug, tracheal tug absent. Percussion not done due to what? Due to fear of thromboembolism. Now auscultation, cardiac cycle, then like 78 per minute as like pulse rate, regular. Mitral S1 swap, S2 audible, S3, S4 not audible. Every student will be asked regarding how to localize apex, how to describe a murmur. So you must have to know. So murmur, so you have to describe like this. This is a high, there is a high pitched, soft blowing pansystolic murmur of grade 4 intensity audible at mitral area, and it's best audible with the diaphragm of the stethoscope and in left lateral position of the patient at the height of expiration, and hand gripping with radiation towards the left axilla and inferior angle of this left scapula. No adventitious sound noted. So you have to remember left sided heart pathology murmur is best heard at the height of expiration, and right sided heart pathology is best heard at the height of inspiration. You may remember the mnemonic left, LEFT. So L then E. So left sided pathology at the height of expiration. Right, RIGST. So right sided pathology, R at the height of inspiration, I at the height of inspiration, I for inspiration. Tricuspid area, the same type of murmur audible at lower with lower gate not intention, lower gate intensity. So it mistakenly written as intention. So it is intensity without any radiation. S1, S2 audible. So it is a conduction murmur, like mitral area murmur is conducting to the tricuspid area. So it is the same type of murmur with lower grade of intensity. Pulmonary area S1 audible, no loud P2 murmur absent. Aortic area S1 audible, no loud A2 murmur absent. Venous carotid area like carotid buoy, pericardial rough absent. So murmur, describe the murmur, apex, what is the definition of precordium, how to look for pasternal hip, and you have to must have to know what is the point, arch point, like neo-aortic area, Gibson area, aortic area, mitral area, pulmonary area, tricuspid area. You have to know the actual landmark and how to localize this. Other systemic examination, respiratory system examination, you must have to examine respiratory system examination, because must have to do respiratory system examination, because if the mediation is shifted, then the apex will be shifted. So you have to mention the position of trachea. Here is the trachea was at central position. So summarizing the case, Mrs. Anjali Bug, normotor and severe Caucasian female belonging to lower middle class family, presented with gradually progressive exertional NOS, is a grade 2 dyspnea and palpitation of 4-month and 3-month duration consecutively. As per history, both are suggestive of cardiac cause. She mentioned a typical history of rheumatic fever during her teenage, and also agreed to have a regular injection 21 days interval. On general examination, mentioned the positive finding, and pulse systemic examination, apex is shifted towards down and outwards, located at 6 intercostal plate, one side lateral to mid-clavicular line. On palpation, mentioned like hyperdynamic with systolic field noted at apex. Detail, mention the detail. I have mentioned shortly, but mention the details. On auscultation, describe the murmur at apex, conduction murmur audible at the tricuspid area. History and clinical exam do not suggest any features of pulmonary arterial hypertension. So remember the features of pulmonary arterial hypertension. So coming to the provisional diagnosis, this is a case of organic mitral incompetence or regurgitation of rheumatic origin without any feature suggestive of pulmonary arterial hypertension, and at the present the patient is in sinus rhythm. Okay, mention like this. So you have to know the features of pulmonary arterial hypertension, you have to know the features of heart failure. And thank you, stay tuned with us and share this video if you are benefited. Thank you.